Welcome. In this video, we will look at how to localize neurological symptoms to the spinal cord. This pattern is called myelopathy. Recognizing myelopathy is important because spinal cord lesions can cause long-term disability if missed. Myelopathy means dysfunction of the spinal cord. The problem may be due to compression, inflammation, vascular injury, trauma, infection, metabolic disease, or tumor. The key is not the exact cause at first, but recognizing that the neurological pattern points to the spinal cord. The classic hallmarks of myelopathy are upper motor neuron signs below the lesion, lower motor neuron signs at the level of the lesion, a sensory level, and bladder or bowel involvement. When the spinal cord is damaged, the motor pathways traveling from the brain to the body are interrupted. This causes upper motor neuron signs below the level of the lesion. These include spastic weakness, increased reflexes, clonus, and an extensor plantar response. At the exact level of the spinal cord lesion, the anterior horn cells or exiting nerve roots may be affected. This can produce lower motor neuron signs at that level, such as focal weakness, reduced reflexes, and sometimes wasting. After identifying myelopathy, the next step is axial localization within the spinal cord. Different tract patterns produce different clinical syndromes. Involvement of the entire cord causes combined motor, sensory, and autonomic features. Dorsal column lesions mainly affect vibration and proprioception, causing sensory ataxia and a positive Romberg sign. Dorsolateral cord involvement affects both the dorsal columns and lateral corticospinal tracts, producing sensory loss with spastic weakness. Anterior cord lesions affect motor pathways and pain temperature pathways, while often sparing vibration and proprioception. Central cord lesions affect crossing spinothalamic fibers, causing segmental pain and temperature loss. Understanding these tract patterns helps narrow the differential diagnosis. A sensory level is one of the most useful signs of spinal cord localization. The patient may describe numbness or reduced sensation below a certain point on the trunk. For example, reduced sensation below the umbilicus suggests a level around T10. The spinal cord also carries autonomic pathways to the bladder and bowel. Therefore, myelopathy can present with urinary urgency, retention, incontinence, or bowel dysfunction. These symptoms are important red flags. The pattern of weakness gives a clue to the level. Cervical cord lesions can affect both arms and legs. Thoracic cord lesions usually affect the legs but spare the arms. Lesions near the conus may affect the legs, bladder, bowel, and saddle sensation. In cervical myelopathy, the lesion is in the neck region of the spinal cord. Because the cervical cord contains pathways to both the arms and legs, patients may have hand clumsiness, arm symptoms, gait disturbance, and upper motor neuron signs in the legs. Thoracic myelopathy typically affects the legs while sparing the arms. A sensory level on the trunk is often helpful. Patients may present with leg stiffness, imbalance, falls, and bladder symptoms. At the lower end of the spinal cord, it is important to distinguish conus medullaris lesions from cauda equina lesions. Conus lesions are still spinal cord lesions and may give mixed upper and lower motor neuron features. Cauda equina lesions affect nerve roots and usually produce lower motor neuron signs. These can be medical emergencies and should be identified early. Once the syndrome of myelopathy is recognized, the next step is to identify the cause. Important causes include spinal cord compression, inflammatory myelitis, vascular lesions, infection, metabolic causes such as vitamin B12 deficiency, and tumors. Once myelopathy is suspected, investigations are used to confirm spinal cord involvement, define the level, and identify the underlying cause. The most important first-line test is an MRI of the spine, especially if compression is suspected. MRI can show cord compression, inflammation, tumor, and abnormal cord signal. MRI brain may be added if demyelination or another central nervous system process is suspected. Blood tests can look for treatable causes, including vitamin B12 deficiency, copper deficiency, inflammation, autoimmune disease, and infection. CSF analysis is useful when inflammatory or infectious myelitis is suspected. Neurophysiology, such as nerve conduction studies and EMG, can help if the diagnosis is unclear or if peripheral nerve disease is also being considered. Most importantly, suspected spinal cord compression requires urgent MRI. Myelopathy can be a neurological emergency. Red flags include new bladder dysfunction, rapidly progressive weakness, a clear sensory level, severe back pain, fever, or a history of cancer. These patients need urgent assessment and imaging. To summarize, myelopathy means spinal cord dysfunction. The key localizing features are upper motor neuron signs below the lesion, lower motor neuron signs at the level, a sensory level, and bladder or bowel involvement. When these features appear together, always think of the spinal cord. Thank you for watching. The most important first step is to recognize the myelopathy pattern. Once you know the lesion is in the spinal cord, you can then localize the level and investigate the underlying cause.